Well, hello everyone. Welcome back to the Cerebral Blood Flow virtual seminar series. I'm Caroline Rickards, one of the co-hosts, and Pat Prasad is also here today as the other co-host of this series. It's my great pleasure to have John Smirl here as our keynote speaker, but I'll just go through a few of our rules for the road as we always do at the start of these sessions. So first of all, just to remind you, we're coming into the home stretch now for this seminar series. So we've got 2 more sessions after this one, wrapping up on the week of December 7th. So keep an eye out for advertisements for those sessions. Please keep your microphone on mute and your video off throughout the session. There will be some time at the end of each presentation to ask questions. I think most of you have been asking questions through the chat function. But if you would like to ask a question verbally, just raise your hand and we'll call on you to ask your question. Also, just as a reminder, the session is being recorded as of now. And so this recording will be posted through the Cerebral Autoregulation Research Network website, and it will be accessible through YouTube. We really do thank everybody for their support for this seminar series. It's been a great experience over these last few months. So hopefully you're enjoying the sessions, and if you've missed any, please check out the Keynote website and you can catch up on your fill of cerebral blood flow physiology for the last few months. And just a reminder also, if you would like to become a member of the Cerebral Autoregulation Research Network, just please send me your CV via email and I can add you to our mailing list. There's no membership fee, so that's a bonus as well. Okay, so let me move on just to briefly introduce Dr. John Smirl. John is a recently employed assistant professor at the University of Calgary in Canada. And John's main area of interest is brain blood flow regulation under various different clinical conditions. He's done a lot of work in regards to concussion injury and also in terms of domestic violence injury as well. And one of the areas of interest and strength for John is actually investigating some of the classic methodologies we use for assessment of cerebral autoregulation. And that's what he'll be focusing on today with the title of his talk, The Use of Driven Blood Pressure Oscillations in Quantifying Cerebral Autoregulation. So John, I'll pass it off to you.
All right, well, thank you, Caroline. First, I just want to say thank you to Caroline and Pat for allowing me to present today on I think kind of a fun topic. It's definitely one that I've been interested in for more than the last decade. And hopefully you can share kind of some of the reasons for that and the applications of this tool. So with that in mind, just want to give a couple shout outs first. So first one is very, very appreciative of all the training I had at UBCO. So working under Dr. Ainsley for my master's and my PhD, I learned an awful lot of skills from him as well as Shek Tenzing. And then I managed to bring those skills from the kind of mechanistic world more into the concussion realm when I worked in the lab of Dr. Paul Van Donkler. And now taking those skill sets and thankfully being able to start my own lab here at University of Calgary. So I also want to say thank you to all the funding agencies that we've been successful with so far, including NSERC, the Libin Institute, about our Children's Hospital and the Hotchkiss Brain Institute, as well as the Canadian Traumatic Brain Injury Research Consortium and the NFL's Scientific Advisory Committee. All right. So I also want to say a big thank you to all the PhD students that are presenting today, including Joel, Lawrence, and Audrey, and I'll give a quick introduction to them when they're about to give their talks. But before we get going, I kind of just want to highlight why I think cerebral blood flow is important. So I think this is a pretty standard recap for I think a lot of people have been in the series so far, but we know the brain's really small compared to the rest of our body. It only weighs about 1,400 grams or 2% of our body size, but it can be a bit of a pig at rest. So it takes up about 20% of our resting oxygen concentrate or content. And if we cut this blood supply off, bad things happen pretty quickly. So the brain doesn't have really ability to store supplies. So if there's not a steady stream coming in, we have a kind of negative outcome. So had some pretty good examples of that in the UFC in the last little while. So I'm a big fan of George St. Pierre. Here's him choking at Michael Bisping. Literally the choke started at I think 43 seconds, and in about 5 to 8 seconds he was completely unconscious. So a pretty solid example of that, brain blood flow being stopped, the brain kind of stops functioning. And another example a little bit more recently from Jermaine Durandame, who again put a choke on in about 5 to 10 seconds, and her opponent was completely unconscious again. So pretty solid examples of that. And the reason for these happening is that the brain has really no nutrient storage, unlike the rest of the body. So if we have reduced blood glucose levels, we can lead to confusion, dizziness, and unconsciousness. And if we have prolonged loss of oxygen, then we get permanent cell damage and death of the brain cells. So if we have blood pooling in our legs, we can have a disruption of blood flow as well. So this little guy was doing a spelling bee, got a little faint, fell over, but thankfully he was able to get back up, spell the word correctly, and I think he got second overall, actually. And if we have more severe disruptions of brain blood flow, there can be much more negative outcomes like strokes. So here's an example of an ischemic stroke happening. So if there's something comes up and ends up blocking one of the blood vessels in the brain, it'll block off blood flow down the areas downstream of that, and it can injure those specific parts of the brain. Whereas if we have a more disruptive injury, like a hemorrhagic stroke, it's when there's a weakening of the cell wall. And then if that bursts, then not only does it disrupt blood flow downstream, but it also increases pressure within the brain and can cause a lot more damage in a lot more areas of the brain. And there's a lot of different control mechanisms that are related to brain blood flow. So we've covered a lot of these in the seminar series, so thank you to all the previous speakers. But with metabolism, if the brain's really active, we get a lot more brain blood flow to the areas. If it's less active, there's less blood flow. If we look at cerebral autoregulation and going by the standard Lassen curve, it should say that there's no differences across a wide range of perfusion pressures, but that just simply isn't the case. So there's been a lot of work since Heistad and Kontos in 1983 that have shown this to be incorrect. And this is a more representative of the kind of regulatory factors. So there's a really narrow window, about 5 to 10 mils of mercury, where brain blood flow is fairly stable. If you go above or below that, we get massive differences in brain blood flow. There's also changes with sympathetic activity. So if there's vasoconstriction, we're going to get a decrease. Decrease in sympathetic, we'll get a dilation. Changes with respect to CO2, and then also oxygen. So if oxygen gets diminished, then we start getting dilation. But really, if it's above about 50 mils of mercury, we're pretty constant for a fairly long way. And then cardiac output, if there's change in cardiac output either above or below our standard levels, we are going to have some changes in brain blood flow. And this is from the review from Kurt and Phil. So the one we're going to talk about today, though, is that role of brain blood flow with respect to blood pressure as an input. And we commonly use that phrase as cerebral autoregulation. So the most common way to assess this is with transfer function analysis. And one of the first main papers to show this was Rong Zhang's 1998 paper, which built off the earlier work from Giller. And basically in this one, they looked at what was going on in the power spectrum density bands. And they kind of saw there was a few peaks that happened. You kind of see there's one over here, another one happening somewhere up here. And so based on that, they called the one happening in the very low area, so 0.02 to 0.07 hertz, was a very low frequency band. The next peak that they saw, they moved that band up to be the low frequency band, which was 0.07 to 0.2 hertz. And then typically the high frequency band was anything in that 0.2 to 0.4, 0.35 hertz range. And though that's where they have these measures, but how do they actually get that information? So I'm just going to take a second here to kind of go over where this stuff comes from. And basically we look at our typical data that we have. So we have brain blood flow here represented in red, blood pressure represented in blue across a 20-second span. We can see all the beat-to-beat changes with systolic and diastolic that we'd expect. And then if we pull that down and take the average data, then we can see what we normally see over a 5-minute span of beat-to-beat data. It's fairly constant, but there are little fluctuations in there. And those little fluctuations are what's causing those spikes to happen in the power spectrum density bands. So basically they look at all this data, they put it through a fast Fourier transform, and it tells us then how much of each of these little changes are happening across that whole data set. So we get our information from there, and then from that we can look at what happens under steady state. So 0 hertz, or basically the average of all that 5 minutes, which is what a lot of us report in a lot of our data sets. We can also look at what happens in that 0.05 hertz range. So typically a 20-second cycle, so 10 seconds down, 10 seconds up. And there's been evidence to show that's related to myogenic tone or calcium channels. There's data that relates back to the myowaves and sympathetic tone, showing spikes around that 0.1 hertz. There's also data in that higher frequency band, which relates to respiratory rates. So if you breathe at 20 times a minute, be a 3-second cycle. And then finally, if we went further past this, you could go up to what happens every beat of the heart and get that information as well. But basically then we take all that, and as we process it through, we can get pretty much 3 main measures out of it. There can be a fourth one too with respect to either absolute or normalized gain. But we get coherence, which is how much these two things relate to each other at any given point. And then phase is how much they're different on the y or the x-axis, and gain is how they're different on the y-axis. So if we look at it from coherence, we get again how well those input and output signals, so how much the blood pressure in the body is relating to the blood flow in the brain on a 0 to 1 scale, 0 meaning they're not related at all, 1 being they're very related. We can also get phase differences. Again, is a difference in the timing of the kind of x-axis time domain differences. Then gain, again, is the difference in the magnitude of the signals, so it depends on how much is going through. And that'll be the difference you see on your y-axis of most of your graphs. So again, this system is considered to be fairly linear when it's close to 1, which is really important when we're using linear transfer function analysis, because it's designed to just use 1 input and 1 output model. So the closer we can get to a 1.0 on this, it's going to give us better indexes of phase and gain. And a low coherence can happen for any number of reasons, and these were the ones that were proposed in the original work from Ron Zhang. So we can have extra noise in the signal. We could have the system just not being related to each other. We could have it having more outputs than the inputs, or the system's not linear in nature. And we know autoregulation has other factors going into play, so number 2 definitely plays a role. And we also know that blood pressure is related to blood flow. So it's definitely not number 4, but the only one we can really address with our methods is typically number 1. And that was one of the main leads in this, well, I guess fairly recent crosstalk debate. It was about 3 years ago, 2017. And we looked at what happens with dynamic cerebral autoregulation, and should be quantified using spontaneous blood pressure fluctuations. So the 2 points of view in this one were we should either use spontaneous CA measures or we should use driven CA measures. So taking the side of spontaneous, we had Shek Tenzing and Ronnie Panerai. And taking the side of the driven measures, we had David Simpson and Jürgen Klassen. And all 4 of these are extremely well-respected people in the fields, and they provided very informative dialogue on the topic. So if you haven't read this one, I really recommend going back to that crosstalk and looking it up. It's got some great points in there. But a quick little summary here is the spontaneous side. Shek and Ronnie were saying that these signals actually are more representative of what's happening in the human body, because it's what we typically experience as we're sitting here and listening to this talk. And we don't need a lot of different equipment or strain on participants to collect the data. So if someone's in a hospital bed or sitting down, we can collect the data really easily, which is a plus. And it also can provide information then on clinically relevant populations. So if you have critically ill patients that can't move or do other things, or severe TBI that are experiencing comas or inability to perform motor tasks, this is a really good way to assess different brain blood flow measures in these populations. And it doesn't evoke extra responses from other regulatory factors. So in that big list I showed you from Kurtz and Phil's review paper, when we're active, we can have changes in our respiratory levels, or we can also have alterations to autonomic function. And so doing just spontaneous measures, we're not getting any of that extra noise coming in that could alter our signals from that. But a big limitation of this one is it does have low coherence, which then adds more variability to our phase and gain measures. So we think of like a coherence of around 0.5, which is what is in the Carnett white paper as acceptable levels. That still means 50% of your signal could be coming from something else other than that blood pressure and affecting our brain blood flow. So it can lead to a lot of variability in those output measures that we report. Going on to the driven side, they presented a really great argument. I think it's probably a little bit too fuzzy to see right now, but basically saying if you're going to take a car for a test drive, you wouldn't just look at it sitting in a parking lot. Sit in a parking lot, every car seems like it's pretty solid, it's stable, it's fine, but you only find out what it can actually do or what the challenges of it are when you push its limits a bit. So you take it out for a test drive. So if you want to stop hard to see if it can brake, you want to accelerate, it's going to be when we challenge those systems is how we're going to see what the deficits in that car are, or in this case, if we cause big swings in blood pressure, we can find out what happens for our brain blood flow and how it can control that. So with that in mind, we can evoke really big swings in blood pressure. So squat stand maneuvers typically can cause changes anywhere from 30 to 70 mils of mercury, which is bigger than most even pharmacological interventions you can do. It happens every single time we do these. So it's actually a really great physiologically representative thing to do, where when we're just sitting here, blood pressure swings typically are only in that kind of 3 to 5 range and maybe get up to about 10 mils of mercury. There's also limitations on certain methods that we use. So there's been a lot of methods proposed. Thigh cuff, for example, has really poor reproducibility. If we do deep breathing, which has been shown to help improve coherence, but then now we're putting big changes into our respiratory factors, and then we're influencing it on cerebrovascular activity levels as well. So there's pros and cons to every method. We just have to know what they are. Another one is that we also might need specialized equipment, so LBMP chambers or lower body negative pressure, if you're not familiar with the literature. And then also participant engagement, so doing squat stands, which can limit which population can do these. So there's a great debate in the crosstalk, which led to a lot of kind of very interesting points of view. And really kind of there's a few summary ones that come out of here, which are, it really does depend on which question you're asking, which population you're working with. And do we have actually an ability to get that better modification to signal to noise ratios? So with that in mind, there's lots of methods again that have been proposed that I just mentioned. So the squat stand maneuvers, which will be the main focus of today's talk, oscillatory lower body negative pressure. There's also been deep breathing and passive leg raises. So passive leg raises didn't really evoke massive changes in coherence. It only got up to about 0.7. Deep breathing, again, has issues with respect to the alterations in CO2. And then also negative pressure has been shown to be quite strong, but you need to go to quite substantial levels of negative pressure to evoke the changes. So the bulk of the talk today is going to be focused on the squat stand maneuvers. And all this comes back to the original work from Tony Birch back in 1995. He did this actually before using transfer function analysis. So actually calculated these ones looking at changes with respect to levels in CO2 and plotted every trace, averaged them for every person, and then looked at what the changes were with respect to either gain on that y-axis, or phase in the x. And the one that's really clear in here is if you look at this under normal capnic levels, these signals are actually offset with the brain happening before the body. And if we go to a hypocapnic state, so they're hyperventilating, that phase difference gets much, much bigger. So again, the brain precedes the body by a substantial margin. And going the other direction, we go back to normal capnic data, and then we do a hypercapnic trial. So if we either did a breath hold or rebreathing task or did a CO2 inhale, now you see that when the blood vessels are dilated, we actually abolish most of that change with respect to that phase parameter. So now they're much more in sync with each other. And you saw this across almost every participant. So we have the different participants across the x-axis here, the phase value on the y-axis. Hypocapnia is in black, normal capnia is in white, and the little trace down here in, I think it's a lighter dotted color, is the hypercapnia. And we pretty much see that in almost every person where we have a big increase in phase if we go to hypercapnia and dilate the blood vessels, where we get a big decrease if we go and hyperventilate or constrict the blood vessels. And again, this work built off of that previous studies by Aslett and Giller, and suggests that this could be a new way we could assess autoregulatory dynamics. But unfortunately, this one kind of sat on the shelf for about 13 years until Jürgen Ben Levine and Ron Zhang kind of re-looked at it. And so in this one, they started using transfer function analysis, and we can see those nice clear perturbations that we get with the squat stand maneuvers. And they compared it either under spontaneous levels at 0.025 hertz, so a 20-second squat with a 20-second stand, 0.05 hertz, so 10-second squat, 10-second stand, or 0.1 hertz, a 5-second squat with a 5-second stand. And one of the things that they did in this one that's different than a lot of the future work that I'm going to talk about is they actually averaged coherence in all the phase and gain measures instead of across the bands like was originally proposed by Rong Zhang, but over the area where the increase in power spectrum density occurred. So there's a couple points either before or after the point estimate, and that led to a few changes that I'll talk about later on. But basically what they saw here was there's a big increase in spectral power. So we look at the y-axis under spontaneous, we're on a scale that only goes to 6 to 10. We're up here, we're now in the 250 to 350 range. So you get a massive increase in the signal to the input signal, which then leads to a more robust estimate of that coherence value. So we get greatly augmented coherences here compared to the spontaneous data, which is in the continuous trace, and the error of the spontaneous, which is in the gray bars. So you see there's a much better input for the coherence level. And with that, we can get some differences compared to gain and phase from that spontaneous data and the driven data. And we get the typical expected results of increases in gain and decreases in phase as we increase our frequency levels. But again, these values don't line up with each other, and likely it's due to a much better signal to noise ratio with the driven data than the spontaneous information. So from this original work, they concluded these maneuvers have an analysis based on spontaneous oscillations that could enhance information obtained from TFA and may be an important step for its translation and implementation in clinical medicine where patients can perform these maneuvers. And there's really these two foundational studies that really got my interest peaked in this area and how this might be able to translate into understanding more about brain blood flow regulation and what we could do if we enhance that signal to noise ratio and get a better message. But what was missing in all these current or previous studies was it didn't actually know about reproducibility. So if we don't have good reproducible results, then it doesn't matter how much we enhance coherence. If it still shows a lot of variance, well, then we don't know if we're getting true estimates of what's going on. So one of my PhD studies, working in Phil's lab and again with Czech, we looked at how this could be done, and we wanted to compare a few different measures. So we did spontaneous supine and spontaneous upright conditions. So either when the brain was at the level of the heart or when the brain was above the level of heart, look at kind of perfusion differences. We also did it with oscillatory lower body negative pressure, as well as squat stand maneuvers. So again, these are the two most common ones in the literature. And we did this in younger and older adults and across 2 different days. So what does the measures look like? Well, similar to what we've seen in the other studies, when we look at our spontaneous data when we're lying down, there's small oscillations and they're kind of inconsistent between the input from the blood pressure and the output in the brain blood flow. And when we drive these ones at negative 50 moles of mercury, we can now see that there are some more steady changes at both frequencies of interest. And we did it at 0.05 and 0.1 hertz. Again, this is indicative of myogenic tone and sympathetic tone. And so when we're viewing this system, this is what it looks like. So when we apply the negative pressure, you see the participants getting sucked in, so blood's getting pulled in their legs. And we have changes that happen in blood flow in the brain in the red, and blood pressure in the blue. And we can see that the brain actually precedes the body in these real-time traces. So I'm sorry that was a little bit loud. But then looking at our upright positions against the squat stand maneuvers when we were seated at baseline, here we have small and inconsistent measures between the input in the body and the output in the brain. And that's what leads to those lower coherence values where now we get really clear oscillations at those frequencies of interest, either 0.05 or 0.1 hertz. So you get massive swings and they're translated all the way up to the brain or the cerebral vasculature. And these ones are quite simple to do. You don't have to go all the way down the floor. Just doing a simple little knee bend to about 90 degrees. Again, you can see those really clear oscillations in blood flow in the brain or blood pressure in the body. And we can also see that the brain's changing before the body. So here there's an increase happening, it's coming down, and now the blood pressure is coming up here. So you can really see those differences with that phase lead happening in real time. So very consistent with what was shown in both Tony Birch's work as well as Jürgen Klassen's work. And then compared to Jürgen Klassen's information here, we can see our power spectrum densities like he was showing, where it's how much is the input coming in from either blood pressure or brain blood flow. And this is between squat stand maneuvers on this side and oscillatory lower body negative pressure. And we look at our point estimates, so those frequencies that we drove it at, we get massive spikes in those inputs. So we're really enhancing that input signal, which then translates to a better output signal as well in the brain. But if we go back to what was being reported on their x-axis in, or y-axis, sorry, in the power spectrum graphs from Jürgen Klassen's work earlier, we did those averages across the area underneath the spike. Their increase was about 300. Well, we're now up to 2,000-ish in the negative pressure maneuvers and almost 20,000 in the squat stance. We've greatly increased our input signals by doing just point estimates. And with that, we get really good results. So in this study, we assessed reproducibility with the measures being performed 48 hours apart. We did it within subject coefficient variation. So we looked at the individual's average score across their standard deviations, times it by 100%, and looked at what was in the literature previously for physiological measures, which said less than 20% is typically deemed acceptable for reproducible measures. And in this graph, we're going to have our spontaneous data first, our driven data with LBNP or squat stands, cross coherence, phase, and gain, with the dark bars being our younger adults and our gray bars being our older adults. In our spontaneous conditions, we can see there's a lot of variability, even in coherence, and massive amounts in our phase, especially like here, in very low frequency, there can be 50% of variance on average between days, and some people vary by over 100%. So if you're using just spontaneous data, you can get massive changes that could be due to just a measurement error or a signal to noise ratio more than just actually the intervention itself. This improves when we look at LBNP, where we get much better coherence, but still there's a lot of variability in here. And this is when coherence was above 0.8 in these measures. When we do our squat stands, now we have coherence that's in the 0.99 range. So we've greatly enhanced that input signal, and it's basically washing out a lot of those other variables that could be causing that extraneous noise. And with that, we get now really good reproducible results on both phase and gain. If we apply that 20% cutoff to it, the only one that actually met this across all the different criteria were the squat stand maneuvers. So in this paper, I propose that they were the highest coherence and most reproducible results. Gives the greatest interpretability if we're doing a examination of just the input-output, which is that linear TFA part of blood pressure and cerebral blood flow, ignoring the other parameters. So didn't call it cerebral autoregulation here, I call it cerebral pressure flow relationships. But I think if we're doing this, this gives us the best measure, and it should be the gold standard that we kind of work with as long as the populations can sustain it. And to look at different populations we've done this in and go through a few different studies. So one of the earlier works I did was in long-term heart transplant recipients. And again, in this population, we were able to evoke these really clear changes in both blood pressure and cerebral blood velocities. And with this data, again, these were performed in both younger and older adults, with our heart transplant recipients being on average almost 10 years after the surgery. So one of the really interesting things in the study was when we looked at our BRS measures, so cardiac baroreceptor sensitivities, in that low frequency gain range, so related to sympathetic tone. And what we saw was under spontaneous conditions, there was really not much happening in the heart rate variability or cardiac BRS in heart transplant recipients, especially compared to donor match controls or even age match controls. And this was really, really clear when we evoked those squat stands. So driving these big, huge swings in blood pressure, big changes in brain blood flow, and their heart rate didn't change. So it's a really clear indication that the cardiac BRS is not needed for the regulation of brain blood flow in terms of cerebral autoregulation. So it's, I think, probably the most clear delineation between those two systems that we could possibly do with a in vivo human model. And again, the reason for this is when we do our cardiac surgery, we actually sever all the nerves to the heart when they're putting it in. So there is no longer any neural input to the SA node. So instead now we have everything driven by hormonal changes. So the heart rate will still change with exercise and recover from that, but it's not going to change on a beat-to-beat basis as quickly when we do these challenges. And then when we looked at the TFA output data, we actually had very good coherence across all the groups, and there wasn't any statistical differences in either phase or gain in either one of these populations. So the heart transplant recipients responded very similar to both the donor and age-matched controls. And this showed that the cardiac BRS really didn't relate to any of the TFA metrics. So it's indicative that one, heart transplant recipient's brain can function quite well on a cerebral autoregulatory standpoint, but also that the cardiac BRS is not really needed for the brain blood flow regulation. So moving on to my postdoc, we did this looking at sport-related concussion. And we did a whole bunch of players we tested at baseline and looked at them for concussion history. So we had people with zero previous history of concussion, 42 of our athletes, and I think we had 179 total. And we had 3 or more in 31 of our participants. And we chose this differentiation because previous work by Kevin Guskowitz has shown that when you have more than 3 previous concussions, you had a 3-fold risk or greater risk of a future concussion. And at baseline between these participants, we actually saw that the ones who had a positive history of concussion reported a higher number of symptoms, as well as a higher severity of those symptoms, despite not having any changes in blood pressure or brain blood flow. And then for our concussed data, we followed all these players from baseline. And then anyone who got injured, we had them come back in a prospective study. Within the first 3 days, we tested them again at 2 weeks, and then also at 1 month. And as expected after an injury, you have a big increase in concussion symptoms, both the number and severity of those symptoms. And they recovered by 2 weeks, which is expected in literature. It's about 10 to 14 days for most people of this age for a concussion recovery. And again, this happened despite not having any changes in blood pressure or brain blood flow. And even with those players being symptomatic, this graph, we have our power spectrum densities with baseline, 72 hours, 2 weeks, and 1 month. We still evoked very similar changes to what I've shown in all the other PSD graphs. And same for our concussion history groups down here. And we were still able to see differences in the 0.1 hertz phase value. So indicative that sympathetic tone is altered following these injuries. And we see it not only at the 2 weeks when they're really, or at the 2 to 3 days when they're really symptomatic, but also still at 2 weeks when they had clinically recovered and they were able to go back to play. And the reason why this is really important is that this is showing that clinical recovery and physiological recovery are not necessarily the same things. But good news for this group was when we compared it to the concussion history, positive and negative groups, is at least in young healthy players, it appears their brains regulate just fine when they've had a chance to recover for an extended period of time. And doesn't look like any cumulative effects yet, but we do need to replicate this in more professional athletes or people who have had a much longer experience with contact sports. And a more recent study from James Fisher and Aaron Phillips groups, they looked at this in another clinical population of atrial fibrillation and did squat stands at 0.1 hertz. And we have healthy controls, AFib patients, as well as hypertensive patients. And in this study, again, they evoked those nice clear responses you'd expect from brain blood flow and blood pressure. And they saw that gain was changed between the atrial fibrillation group and the healthy controls, as well as the hypertensive populations. And then healthy controls and hypertensive also showed a difference in phase values, but AFib wasn't different between those ones. And this is another area that's showing that using squat stands, they're applicable to a clinical population, and they're also very sensitive to showing changes with respect to differences in these groups. So moving forward from that, I'm going to talk a little bit about different kind of physiological parameters we've evoked changes in this group. So one of the studies I did in my PhD, which I think is being talked about in a few other groups, is we went up to Mount Everest base camp area at the KNRCV E2 Pyramid Lab at 5,050 meters. And basically we did all of our baseline measures in Kelowna at sea level. And then we flew into Kathmandu and then up to Lukla, which is a crazy, crazy airport. This runway is only 400 meters long. You have a mountain face on one side and another mountain cliff up here. It's about 14-degree slope. So literally you come in and it looks like you're about to crash, and then you just pull up there. Then we hiked up to Namche Bazaar, which is 3,400 meters elevation, a very beautiful little city in the middle of the region there. And then we had a stay at Farishay to get everyone ready to go for heading up to the Pyramid Lab. And by the time I got here, everyone who's in this study will attest that I was not feeling well. So I was pretty rough there for a while. And I want to say a big thank you to Nia and Sam Lucas for helping collect my data on the day 2 arrival day, because I was not physically capable of it there. And then arriving up to the Pyramid Lab at 5,050 meters, we were able to collect our data. Again, thank you to Sam for helping me out with this data collection and being one of the subjects in the study, and reflected it in ourselves at day 2 as well as 2 weeks, so once we had done partial acclimatization. And this is contrasting a lot of the literature before that either did C-level to acute, C-level to acclimatized, or when you're up there and you returned, no one had done a study that actually looked at all the different changes all the way through, or had used driven metrics. And we also tested Sherpa populations up there, and they were actually really good sports, wanting to learn more about our measures, and even had a little bit of fun playing with the equipment and kind of joking with each other. So they were a great group, and if you ever have a chance to go up to the Kumbh region of Nepal, I highly recommend it. So this was our group, and here's Mount Everest up in the background. And we were very fortunate to be able to get up there and see a really clear blue sky sunrise over Mount Everest, which is one of the most amazing things I've ever seen in my life. So getting back to the science though, again, we saw big changes across our O2 saturation as we went up to altitude, as we would expect. When we did a reversal, we returned back to sea level levels, which was good. And we have differences in brain blood flow in the Sherpa, as well as cerebrovascular resistance in that population. And then when we compared this to all of our data across every different aspect of it, we actually didn't see any differences in squat stand measures for either 0.05 or 0.1 hertz in the MCA or the PCA, really. And if you want to look at that in a more visual sense, here's our C-level day 2 to week 2 data, so our partial acclimatization level, and we don't have any significant differences across any of these measures as we go through. So in contrast to a lot of the previous literature showed changes with spontaneous TFA metrics at altitude, we didn't see them at all with driven measures. So it might have just been an issue with signal-to-noise ratios in that previous data. Moving on to another physiological study, we looked at changes in cerebrovascular resistance, either pharmacologically evoked with indomethacin or non-pharmacologically evoked with hyperventilation. And the important thing about these ones is either of those parameters don't actually change systemic blood pressure. So here's our no intervention data. We can see blood pressure was going between 100 and 120, 130, whereas blood pressure stayed roughly in those same levels when we did either intervention, but we do have big reductions in our brain blood flow levels. So we were able to evoke changes. So we did the indomethacin on day 1, and then we did a matched hyperventilation control to get them down to the exact same levels of brain blood flow. And during our squat stands, we can still see that we get clear oscillations in all the traces. So again, blood pressure is unchanged, as we can see all the similar levels of our power spectrum density graphs. But our input signal is vastly different when we look at it, because we did that increase the cerebrovascular resistance. So in our no intervention, we have a really big signal, but massively blunted that when we did our interventions. We see that again in the MCA and the PCA. That's when we, unlike the last study, showed no differences. We actually had differences across the board for the intervention. So comparable results basically between endo and hyperventilation on phase gain and normalized gain across almost all the parameters in both the MCA and the PCA. So it shows that we can do these squat stands that create massive perturbations in blood pressure, but we can still regulate our diameter or blood vessel diameters around that, so it is not overwhelming the system. Okay, moving on to kind of a more recent update on a lot of this stuff from Ronnie Panerais' group. They've looked at a bunch of different aspects of this in a series of recent papers. And so I'm just going to touch on these really, really quickly. So when we look at the first one, which is directional sensitivity, so looking at differences between squatting and standing. We're looking at the depth of the squats. Can we randomize them, or how many squats do you have to perform? So the first one again is that differential one. So the circles here are when we're squatting down, so we're engaging that skeletal muscle pump. We get massive increase in blood pressure, which we can translate up into our brain blood flow levels. And then because we have a big increase in blood pressure, we have an offset decrease in heart rate, which we would expect. Whereas if we're standing, we now get a decrease in blood pressure and an increase in heart rate to offset that change. And again, we see that decrease in blood pressure also being reflected by a decrease in brain blood flow. So if Lassen's curve was true that there was no change between 50 and 150 mils of mercury, we wouldn't see these results over here. And then the other one here is looking at changes between day 1 and day 2. And you see that they're pretty robust and reliable between the different days. So the next paper they're looking at was, does squat stand measures differ? And basically they looked at doing a really, really super deep squat or just sitting down until you rested on a medical bed. And again, this is in contrast to the ones that I've employed in all the other studies that I've talked about today, which shows people squatting down to about a 90-degree bend in the back of their leg, which really does a good job of enhancing skeletal muscle pumps, but also is very feasible in clinical populations. So that's a big difference between what they're reporting and what our group has been reporting for the previous set of studies. And when we look at these ones, we have our deeper squats or our shallower squats. They both evoke pretty large swings in blood pressure and pretty big swings in cerebral blood velocities, but a little tiny bit lower in the shallower squats, but they're still evoking clear changes. And they look at the coherence levels, we get massive increase with those point estimates as we'd expect. And this is between the deep and the shallows. We get fairly consistent measures between our gain phase values. But in contrast to the other literature, which I showed you, no differences in younger and older adults, they actually showed substantial differences between phase and gain in those younger and older adults, especially for the phase values here. So 0.8 versus 1.1 and 0.5 versus 0.6. So unlike the previous literature, they actually did have an aging difference, which I think we need to look at a little bit more. It might be related to how extreme the two squats were. And then moving on into their randomized trials, so either they did them in a controlled way, so much like what I've done in all my other ones where we follow a metronome, go down on standard depth and up, standard depth and up. This one they did it at different frequencies. So instead of doing a point estimate, this would allow us to do those kind of band estimates that were done previously, similar to the first work by Rong Zhang. And if we look at the data from this study, we get coherence values again greatly increased between the days when we look at our fixed squats. They're not quite as high, but they're still quite good doing the randoms. And then we also get fairly reproducible phase and gain values. Again, phase values, sorry. But there's a big difference here. And that's if we look at our fixed values, our fixed or random squats, those higher coherences, we get better reproducible results, although there is some variation here. Compare this to the between day visits on standing data or sitting, and we get massive changes in the values. Like for example, here gain is at 0.6, where here is at 1.0. Low frequency goes from 1 to a 2, so again, that almost 100% increase that I was talking about earlier. So again, those spontaneous values that are often reported in literature lead to very, very high levels of variance, which greatly impacts our ability to interpret anything from those data points. I'm a big, big proponent of doing the driven data because if we're going to do TFA, it's a linear system. We need to linearize the system to get meaningful outcomes. And then we looked at this one for their final study where they did those controlled depths, but then looked at how many squats are needed to evoke increases. They did a point estimate on each one and did it either at 3, 6, 9, 12, or 15, so at 0.05 hertz at 1 minute, 2, 3, 4, or 5. And the coherence was augmented in pretty much everyone once you got up to a decent amount of squats. But unlike the other literature that's showing everyone at about 0.99, they actually have most of the people down here at 0.9 to 0.95, so I'm not exactly sure what's happening there. But it does show that if you have a little bit longer data set, you do get more reproducible and robust results. Again, there's a limit to this, which is it hasn't been replicated at 0.1 hertz, or it hasn't been looked at across other vessels in the brain, or at other frequencies. And then there's another limitation that I want to address that I'm guilty of in all the studies that I've shown you guys so far, and that's that I only looked at the mean data because that's what was typically in the literature. But since in my postdoc, I kind of started looking at this a little bit more closely. And when we look at these traces, we can see blood pressure here. And if we overlay our diastolic and our systolic traces, we can kind of see that they actually look fairly similar. So similar heights, similar depths, and similar timing points of each one. Whereas if we look at brain blood flow, we get our diastolic changes, and look at systolic, we actually get a big blunting in that systolic signal. So if we overlay them, instead of lining up really nicely, you see that there's big gaps between these signals. Oops. Not only in respect to the height of them, but also the timing between them. So it looks like there's something going on that's changing in the systolic side much more than that diastolic side. So that's something I wanted to examine in the study. So look at the power spectrum graphs. And blood pressure, as you'd expect, diastolic because it's got a lower value, it's got a lower input. Mean is in the middle, systolic is the highest input levels. The opposite is what we see in the brain. We actually got the highest input levels when we looked at our diastolic values, and our lowest when we looked at our systolic, at either the 0.05 or the 0.1 hertz ranges. So the brain's obviously doing something very, very different than the body here. And so we look at our coherence values. Again, doing the squats, we do get high coherence across all the different levels, including those at systolic, but systolic was lower than mean and diastole, with our kind of goldy colored bars here being 0.05 hertz, or black being 0.1. And then we look at our phase values. Again, that phase, so that timing that we saw on those signals, is much, much greater with respect to systole than diastole. And diastole and mean actually weren't different at all. But we still saw the expected kind of changes between 0.05 and 0.1 hertz. So there's a decrease in phase in either aspect of them. Moving on to our gain measures and absolute gain. In contrast to this, where we see big change in systolic and then no changes between mean and diastole, we actually get changes across the entire cardiac cycle. So there's big changes in diastole for gain, so there's more signal being passed through. And there's a big blunting of that signal with respect to systolic. And we see the same thing if we look at it in terms of normalized units. So basically this shows that we get really high coherences, and mean and diastole is comparable in phase, but they're very different when we look at gain. So I think if we added in measures, so looking at just the mean traces and start looking at diastole and systole, we're going to start getting a lot more meaningful information about challenges that can happen to the cerebrovasculature. And especially in that systolic side, I think that's where we get the most blunting and most protective nature going on for the brain, likely due to the Monroe-Kelly doctrine, which is that we only have so much space inside the skull. If we try and put more in there, it's not going to work. So it's going to dampen those to protect over perfusion. So I think future studies should be looking at systolic oscillations because those are the biggest buffering levels. And if there's changes to that, then it could put the brain at increased risks. Diastolic oscillations are relatively unaltered, so they're much closer to being kind of pressure passive, if you want to use that language. And again, I think the systolic buffering is due to a protective nature to prevent overperfusion, reduce the risk of cerebral hemorrhages, and provide better outcomes for people in general, because if our brain wasn't able to protect against overperfusion, then anytime we exercised at moderate levels or held our breath or did a squat, then there'd be a great risk of having those blood vessels rupture, and that wouldn't be a good thing for us at all. So just to wrap up, I want to go back to the crosstalk debate, say a big thank you again to Sheck, Ronnie, David Simpson, and Jürgen Klassen, and just highlight their last words that they did. I think they did a great job presenting all the information here, and I hope I did a decent job summarizing at least the driven method side of it. But just going to pull out a couple key points from both parts is that the spontaneous side agree that the idea of a multimodal toolbox provides more information from a physiological perspective. And the challenging here is to find those perturbations and give that maximum information, which I think we've seen by Ronnie now since this coming out in 2017 to publish those 4 papers using squat stands in 2018 and onwards. And then also Jürgen and David presenting that they realize there's still plenty of work ahead, and it's satisfying to see that engagement and open debate is only going to further this progress. I think that's very, very true. So I just want to say thank you to them for all the work they've done. Thank you to Tony Birch and Jürgen again for those preliminary works for squat stands, as well as Phil for all of his guidance over the years, and Paul for allowing me to be a postdoc in his lab. And just want to say thank you and open up the floor to questions.
Thanks so much, John. That was a great presentation, really comprehensive review of this approach for assessment of pressure flow relationships. So I think it's going to be a great resource for this seminar series. So thank you. We have one question already in the chat, and please, if you have additional questions, audience, please post them in the chat, and I'll address those with John. So the first question is from João Gomez. Great talk, thanks. He's asking how would you translate this to the bedside of a critically ill patient with brain injury? What would be the best way to replicate the maneuver to obtain driven data?
The best way would be to ideally have them hooked up to a passive cycloergometer in a negative pressure chamber if we could. I didn't have a chance to present that data, but I've done that in healthy people, and you can evoke very similar blood flow oscillations as you can with squat stands. And there is evidence in severe TBI of doing passive cycling to help improve recovery trajectories, or improves leg strength, and also clinical outcomes, reduces hospital stays, and gets it back to as good a life, as quick as life as possible. So that'd be the best way to go. It'd be a very difficult thing to set up and organize, but you have to build a bit of a custom box you can slide around the bed and do it that way. So it would not be easy.
What about using things like repeated cuff inflation, deflation? I don't know what the magnitude of change is with that kind of approach, but that seems like a little bit more practical, I guess.
It's more practical, but the reproducibility just isn't there.
Mm-hmm.
So again, you're going to go back to the spontaneous data where doing that, you will get increases, but it's going to be very noisy, and it won't lead to as robust results as we would like.
Okay, great. I've got another question in the chat from Justin Sprick. Very nice talk. I have two questions. First one, is there any interaction in autoregulatory capacity between the two frequency ranges? For example, if autoregulation is impaired in the VLF range within a particular population, is there compensation through an enhanced autoregulation in the low frequency range?
I have not seen that, but that is a fabulous question. They seem to function as somewhat independent areas of regulation. So much more the 0.1 hertz is indicative of those microwaves that we see in blood pressure. And so it's much more in line with what happens for sympathetic regulation. And then myogenic or calcium channels seem to be more going on with respect to the 0.05 hertz levels. And we can see differences in either frequency depending on different populations, but most often I've seen it at 0.1 hertz. So it seems like there's been more challenges to use sympathetics in regulating blood flow after an injury or after different clinical groups than I've seen in 0.05 hertz. So I don't see a compensation at the lower levels. I just see an impairment at the little bit higher frequency.
Sure, great. The second part of Justin's question is, do you think that long-term treatment with a medication that acts on a specific mechanism of autoregulation, for example, calcium channel blockers acting in the VLF range, could that cause such an increased sensitivity in the other frequency range?
I honestly don't know, but I think it's worth investigating down the road. I definitely want to do some interventions from a exercise point of view for concussion and try and look at ways we can use this information to help improve concussion recoveries, and that's going to be the focus of my lab for the next few years. So I do think it's going to play a role for clinical populations, and we can use it to help inform outcomes. Specific to calcium channel blockades, I haven't done enough work in that area to be able to tell you, but I do think we do need work in that area to find out. So if you want to chat about potential studies, I'm always happy to hear them.
Justin's giving away all these research ideas here. So anyway, we have another question from Pedro Paulo Soares. He says, great, thanks, great talk. I expect sympathetic oscillations at 0.1 hertz, but what about the neural mechanisms in the VLF band? It would just be mechanical oscillations due to blood pressure, is the question.
I think we need to do some more advanced imaging techniques to know for sure. So I think the limitation again of TCD is that we're doing deeper brain structures. So to combine this with other methods like fMIRS, EEG, to look at them with respect to different areas of the brain and their activation levels across the different tasks, then we'll be able to address that a little bit more. With the information I've got right now, I can't say yay or nay to that.
Okay. Next question is from Ron Schondorf, and this is kind of a great question in terms of the philosophical issues related to autoregulation. So how do you distinguish between impaired autoregulation and autoregulation not expressed because other mechanisms are perhaps more important?
So great question, great talking point. I didn't present the data from my IPV studies or our soccer writing, some other data that I presented previously at CARNET. But basically, I really don't like the lingo of impaired or improved autoregulation, because typically we've done that based on hypercapnic, hypocapnic data to show that if there's a bigger buffering, like we see with hyperventilation, we call it improved autoregulation. If we have a decrease in it, like we saw with the clear changes in hypercapnic trials in Tony Burke's data that I presented, we call that impaired autoregulation. Well, the problem I have is that when we did our IPV study, we actually saw them having increases in phase after repeated brain injuries. And the ones who reported the highest level of brain injury had the biggest differences in that domain. So if we did the typical literature, we would say, that's improved. It's great, the brain's doing better, but it also is just indicative that the brain now is no longer able to respond properly and it's actually stiffened. So I think we have to go to the language of altered and describe how that alteration is going on in a clinically relevant context, to put it in perspective instead of just going with the standard. It changes similar to how it does with CO2, therefore it's either improved or impaired. I think we say it's altered and then describe how and why that alteration probably occurred will be much, much more meaningful in the long run.
Yeah, I agree, John. I think the lack of a kind of known normal range, I think there's so much variability in these measures that we don't know what is quote unquote normal to be able to claim that something's deviating from that. So I think it's a good point. I just had a follow-up question. We've got two more. I'll just quickly, in regards to the role of CO2 on these responses. So I presume you're not controlling CO2 throughout the squat to stand maneuvers. So how do you control for that in terms of the magnitude of response you're seeing in the cerebral blood flow measures?
So we are watching their breathing patterns every single breath, and we have our entitles pulled up on the screens as we collect data. So we're able to actually monitor their changes and make sure they're not being either hypercapnic or hypocapnic. So try and keep them at the same levels they were prior to the studies. And that's what we can kind of see in these traces here. We're even doing the endo, we get very consistent entitles all the way across at every frequency, and we can control them even with hyperventilation at those lower levels. So we can do a really good job of controlling breathing as we do it. We just have to watch them, and we don't let them just do it willy-nilly, but we do follow everything as we're going on and keep a very close eye on the data just to avoid any potential confounders of that. So great question, great point.
Great. And I'll just ask one last question from James Fisher. I know João Gomez has another question. I'll let you perhaps address that in the chat afterwards, John. But James Fisher has a question regarding the TCD measures velocity, not flow, as we all know. Have internal carotid artery TFA responses to LBMP-induced oscillations been assessed? And do these, or would you expect these to match with the MCAV responses captured with TCD?
I don't know, because of the limitations of the technology to do it. Holding a signal during an oscillatory negative pressure chamber would be very, very difficult, because if you watch that video, which I'll just pull up here really quickly, you actually see how much the head and body move. So they're coming down a good inch or so to try and keep it in line. It'd be very difficult to actually hold those signals the whole way through. So I haven't seen that data. I don't know what it looks like. I would hope they would match, but again, I couldn't say it for sure. So great question. And
we're actually collecting that data at the moment, so stay tuned. So
awesome.
it is a challenge though. It's definitely a challenge.
That one's better at collecting that data than I am then.
No,
awesome.
not me, it's my trainees for sure. All right, John, I think we'll wrap up your section now. I'll pass it off to you to introduce your presentations from the trainees in this session. Thanks so much.
Thank you. Thank you everyone for being part of our seminar series today. And just want to introduce our next speaker, who's going to be a person I've worked with during his undergrad actually at UBCO, and then he came to University of Calgary for his master's, and fortunately or unfortunately, I'm not sure which, but he's decided to come back and work with me again for his PhD. And so just going to introduce Joel Burma, who is a PhD student now at University of Calgary here with myself, as well as Jeff Dunn. And he's looking at methodological considerations when using squat stand maneuvers to assess the cerebral pressure flow relationship. Take it away, Joel.
All right, so I just want to start by saying thanks to Carolyn and Patrice for putting on these amazing seminars. They are super informative, and I've been loving them. So as John mentioned, I'm a first-year PhD student at the University of Calgary, working with him and Jeff Dunn. So to start my presentation, I'm going to get everyone to do something. Don't worry, it's not squats or anything like that. I'm going to get you to pretend you are this individual on the sideline here, and you are watching this game. You arrive in your mobile lab testing unit that is equipped with TCD, your FinaPress, everything you need to measure autoregulation. And while you're at the event, you witness this play. You see a player get hit, they come down and hit their head on the ground. Now, they come off and they're complaining they have a headache, they're feeling a bit dizzy, they're not feeling right, and they're diagnosed with a concussion. And as John mentioned, we see a deficit in autoregulation within the first 72 hours, as well as 2 weeks following the injury, which typically recovered by 1 month, as found in this study. So with that knowledge, you think, I'm at the game, I have my equipment, how quickly or when can I collect data on this individual to see the very acute phase of concussion on the autoregulatory measures? However, I kind of use this as an example as I thought it was a great way. There are several important considerations that we need to take before we can collect these measures to ensure that they are reliable and valid. And a lot of these considerations, or this work that I completed was during my undergraduate degree, working with John Smirl, and I'll be touching upon 4 today. So the first and the biggest one is the acute effects of exercise. So if we go back to our example, how long do we have to wait following the sporting event or following the injury to ensure that any changes are actually due to a concussion rather than just the acute effects of playing football? Second, as John briefly touched upon, I will kind of dive a bit more into it, the importance of examining the cardiac cycle with diastole and systole. Third, looking at diurnal variation. Again, if we go back to our example, sporting events happen across the day. So if we are, if someone gets a concussion at 10 a.m. versus 5 p.m., are we able to compare those measures, especially within a lot of, laboratories? It's hard to get individuals to come back at the same time of the day for every single testing session. So are we able to, have participants come in at 11 a.m. one day, 3 p.m. the next day, 1 p.m. 2 weeks down the road? And then finally, I'll touch upon the differences in biological sex. And this is kind of, I really enjoy, I think this is an important aspect just because there's a lot of research within females currently missing. And I think this is going to be something that's super important because it's half the population. And if we, if there are no differences, males and females, obviously this allows us to increase our sample sizes, especially within, when we think about clinical populations, having them included within control groups. So for the first aspect, I'll be talking about one of my published studies, and this was looking at the acute effects of exercise. This work that this study had 2 kind of reasons why we did it. One was the vested interest in concussion, as previously described. But the other one also was, while I was kind of getting into my feet wet in the realm of autoregulation, I noticed a lot of articles within the method section just stated that we're restricting exercise for about 12 to 24 hours prior to data collection. And this is the white pages from the Carnet group. And you can see that even within there, it says the minimum of 12 hours. And you can also see that it says recommendation number 1. So it's a pretty important kind of detailing the basics of what do we need to do to ensure we have good measures. So with that in mind, John and I kind of sought out to think, can we develop a more objective time frame? Is this 12 hours enough? Is it not enough? So we developed a study where we had 9 participants perform 3 different conditions. One was a control day. The second was a moderate intensity continuous day. And then the third was a high intensity interval day. So what it looked like is participants came in, they performed baseline measures, which consisted of neurovascular coupling assessments, autonomic function, autoregulation, as well as a cerebrovascular reactivity. After this, they performed one of 3 randomized conditions on separate days. So they performed those. And then there were Then they perform serial follow-ups at hours 0, 1, 2, 4, 6, and 8 after exercise. And then this was done as a conservative safeguard just to ensure that they indeed were back to baseline resting levels. For the sake of this talk, I'm only going to be touching upon the autoregulation aspects. However, I just thought I'd throw it out there that also the CVR and the autonomic aspects of this are published. And hopefully the neurovascular coupling and the convergence will be early 2021. So if we go to the results, as John mentioned, we see this typical differential regulation happening between systole and then mean and diastole. And this is very evident within the phase as well as the gain. However, when we looked at this following the high intensity interval, we saw that this differential was abolished. Systole was not different anymore than the mean or diastole within the phase, indicative of something's happening to the cerebrovasculature. And we also saw this within the moderate intensity, seeing that this differential regulation disappeared. And for both of these conditions, we found that it came back at hour 6. And from here, essentially, we looked at it and said, okay, it does appear that 6 hours is sufficient for the cerebrovasculature to return similar back to baseline levels. And this kind of alluded into the next point that I would like to, or a nice segue, and as John talked about, differences in the cardiac cycle. So here we have two traces. One is a MCA blood velocity as measured through transcranial Doppler ultrasound, and the other is a blood pressure in blue. So this is very similar to what John did. If we overlay the diastolic TCD and blood pressure traces, we see that they're both very similar. When we do the same for the mean, we can see again, they're pretty similar, a bit more divergency. However, when we do this with the systolic and overlay them, there's a substantial difference happening, which is attributable, which as John mentioned, to just the kind of survival mechanism, right? So if we think about this from a more clinical perspective, if the brain is, blood is allowed to pass through the brain relatively impeded and is allowed to just go where it wants, well, this is not good. It could lead to hemorrhagic strokes. It could lead to, aneurysms, etc. So just by examining the mean alone within the, past study, we wouldn't have seen the true intricacies that we saw of the change in autoregulation following exercise. And I know one thing I was kind of thinking of while doing this talk is, it'd be really cool to see especially what happens within the systolic components following, in individuals who have hypertension or diabetes or something like that, where there's constant inflammation and the vasculature, the systolic component is constantly being worked. I definitely think that would be something, be super cool down the line to see differences here and there. And this idea has actually been around for quite a long time, or for the past 15 years. And it was first brought up by Ogo and colleagues in 2005, 2007, where they examined the diastolic and systolic components following exercise using spontaneous measures. And in recent years as well, our group has done a bit of it with the squat stands in concussion in healthy individuals. The next point I'll be touching upon today is diurnal variation. So just looking at how these measures change across the day. So in our study, we had individuals come in at 8 a.m. and they performed 7 follow-ups across the day. This was in 16 subjects, 8 males and 8 females, where the first one took place at 8 a.m. and the last one took place around just after 5. So essentially we had this data from 8 to 6 p.m., which gave us a 10-hour window where we examined differences in autoregulation. And in this, we found that there were relatively no changes across the day, which gives us increased ability to test for the reasons I mentioned earlier. Especially if we go back to the concussion example, we don't know when someone's going to get a concussion. Is it going to be in the morning, in the evening? Sports are played all across the day. So having this increased time to test active individuals just allows us to, have more participants come in and collect more data. As well, I'm sure, everyone's had this experience. You're about to run a study and then someone accidentally bikes into the lab. So now you have to push their testing back a little bit just because they exercised on the way there. So again, you don't have to scrap the whole day. This gives us the idea that, okay, they biked in at 8 a.m., given the 6 hours, we can test them at 2 or sometimes after that. And the final aspect of this study is that we compared differences between males and females, and we found no differences across the phase gain and the normalized gain metrics. However, this is with the important caveat that we only assessed females within the days 3 to 7 of the earlier follicular phase of the menstrual cycle, as this is when hormones are known to be relatively the most stable, as well as body temperature is known to be, pretty consistent. So more research is needed to, understand how these measures change across the different phases of the menstrual cycle. But nonetheless, this does allow us to, increase our sample sizes, given that we can, having control groups that contain males and females, knowing that they give similar estimates, which is awesome. So if we look at the take-home messages, one, we developed a relatively objective time frame of 6 hours following exercise for these measures to return back to baseline. 2, we saw the importance in both this and John's presentation of examining these measures across the cardiac cycle, not just within the mean aspect. And this becomes especially paramount within the clinical populations. 3, we saw the lack of changes across the typical workday, so between 8 a.m. and 6 p.m., which enhances testing, as well as we saw no difference between males and females, with the caveat that females are tested days 3 to 7 of the earlier follicular phase of the menstrual cycle. I'd like to give a big acknowledgement to everyone in my lab, especially those for those who tuned in today, as well as all my funding sources. And thank you for allowing me to come. I have an email there. If you have any questions or comments, or if you're watching this later recorded, feel free to shoot me an email. I'll be happy to answer any questions.
And up next, we're going to have Lawrence Reck, who is a PhD student from the University of Laval, present, working alongside Patrice Bissard. And her talk today is on the utilization of the repeated squat stand model for studying the directional behavior of the cerebral pressure flow relationship.
All right, so thank you, John. And I also want to thank Dr. Rickards and my own supervisor, Patrice, for organizing these seminars. As a student, I can confirm they have a boosting effect on motivation in the COVID context. So I'm pretty excited to be presenting today, since I'll present some fresh results from our lab where we did a time domain analysis of repeated squat stands. So we've been a lot in the frequency domain in the last 2 presentations, but I'll be in the time domain. So as most of you know, dynamic cerebral autoregulation defines the ability of the cerebral vasculature to react to rapid blood pressure changes. And more literature tends to show an hysteresis-like pattern in this relationship, describing the fact that dynamic cerebral autoregulation seems to be better adapted to compensate for elevating than for lowering blood pressure. And these graph here demonstrate the hysteresis. So depicted in blue is when blood pressure decreases, and in red when blood pressure increases. And we notice that the slope are greater when blood pressure decreases, depending on the metric we are using. So this hysteresis-like pattern is thought to serve as a protective mechanism against blood pressure surges, since the brain is located in an inflexible structure. And one of the best recognized techniques to evaluate DCA, and it has been well presented, are repeated squat stands. So as John and Joel very well presented, they produced a periodic stimulus creating large oscillations in mean arterial pressure, or MAP, and they are transferred to cerebral blood flow. And it's usually estimated as with the middle cerebral artery mean blood velocity, or MCAV. So repeated squat stands are used to analyze the pressure flow relationship in the frequency domain. However, that does not take into consideration the direction of the map, making it impossible to evaluate hysteresis. This is why it is interesting to analyze the cyclic physiological stress in the time domain. So for example, a few members of our team a few years ago calculated a ratio between MAP and MCAV during squats, and they show that it was lower for the part of the squats where blood pressure is actually increasing than when it was decreasing. So they demonstrated the hysteresis pattern with this technique. More recently, Panery's team, instead of calculating a ratio, calculated the autoregulation index for each squat of the repeated 5-minute squat stands. And here you have, on the y-axis, the ARI, and on the x-axis, you have all the squats. And in the black dots, you have when pressure increases, and in the empty dots, you have when blood pressure decreases. And the ARI, they demonstrated that the ARI was greater when blood pressure increases, again, showing an hysteresis pattern. So these two studies demonstrate the presence of hysteresis and the usefulness of repeated squat stand to assess it. More specifically, in the 2017 paper, How Did We Calculate the Ratio as an Indice of Dynamic Cerebral Autoregulation? So this is a ratio you're going to see throughout my presentation, and it represents a relative change in MCAV for a given relative change in MAP. So more specifically, what do we do? The first thing we do is that we identify all the maximums and the minimums. And then we compare them to a separate resting baseline. However, this approach was recently criticized, and their argument was that while we are on a seated baseline, the resting values are higher than a standing one, for example, and that could create greater oscillations when, for example, comparing to minimum values. Then they suggested we should use a standing baseline. While we agree using a separate seated baseline can be misleading, the standing baseline is associated with lower resting values, and we think it could also cause greater size of oscillation when we compare it to maximums. So then maybe it could balance the presence or not of hysteresis. And also we think that using a value from a prolonged standing period could cause orthostatic hypotension and also be misleading. So we are in a situation where we have no real baseline we can employ to calculate our ratio and evaluate hysteresis. So then we just wonder, what if instead of using a separate resting baseline to compare our value, we would use the actual changes that are occurring for real when we do squat stands? So instead of comparing our maximums and our minimums to a baseline value, we would compare them between each others. So that's what brought us to our first hypothesis, our first objective, sorry. That was to calculate a ratio metric, but using the largest concurrent MAP oscillation induced by the repeated squat stand instead of comparing it to a baseline value. Also, since we averaged the ratio of each squat over the 5 minutes for each MAP direction, we wanted to ensure the metric remains stable, and we did wanted to ensure the induced stress is comparable with the addition of squat stands. So we wanted to evaluate, as a second objective, the stability of the ratio over time. So to do this, we add a set of data from Université Laval here in Quebec, as well as a set of data from UBCO. And then after a snack and a familiarization, our subject did a 5-minute standing rest, and then they went for both squat frequency for 5 minutes, and the squats were randomly assigned. Of course, we had a transcranial Doppler to evaluate MCAV. MAP was measured continuously with photoplethysmography, and we had a gas analyzer, and we were specifically interested in PET CO2. So how did we calculate our ratio while not using a baseline? So what we did is when blood pressure acutely decreased, so when the subject stands from the squatting position, we took the maximums and we calculate a ratio with the following minimums. Whereas for when blood pressure increases, so when the subject squats down, we took the minimums and the following maximums to calculate a ratio that are here. So as a result, we had 74 subjects, and there was 9 women into this subject. So we had a cohort of healthy subjects with normal resting values. So the first thing we were interested in were the absolute values during the absolute values of change for both MAP and MCAV during the squats. So either when blood pressure was decreasing or increasing, the values were similar between the MAP direction and the frequency of the squats. As well, you have to know that PET CO2 was similar between both frequencies during the squats. So regarding our ratio, what we observe is a greater ratio for when MAP acutely decreases than when it acutely increases. So here we can observe a hysteresis pattern that is still present, although we use a different calculation than from the 2017 paper. So there was a 7% increase for a ratio when blood pressure acutely decreased in the 0.05 Hertz, whereas it was an 18% increase for the 0.1 Hertz squats. So as I told you sooner, we were also interested in the stability of the data over the additions of squats, and we really see that depending on the direction of the blood pressure or the frequency of the squats, it was pretty stable. So what we did is that for each squat, we took all the subjects and did an average with this. However, we did notice a greater variability in the 0.1 Hertz ratio when blood pressure decreased. And we were a bit questioned about this, and we therefore decided to calculate the coefficient of variation to characterize this variability. So the result were that there was an ANOVA map direction effect, and multiple comparison revealed a greater variability for when MAP acutely decreases than when it acutely increases. So we are not really able to explain this for now, but we have observed this. So as a conclusion, the first thing we are able to say is that there is still hysteresis, although we change the technique of calculation. So our analysis ensures the hysteresis pattern was not issued from an inadequate calculation, and it also reinforced that repeated squat-in analysis in the time domain is a valuable technique to assess DCA and the hysteresis. We also found out that the repetition of the same stimulus over the 5 minutes produces valid and stable data over time, reducing the potential influence of outliers, which is really interesting. And of course, we found a variability when blood pressure acutely decreased for both frequency, and for now, we cannot really explain this finding. Of course, we had some limitations. So we only have healthy subjects and we can't transpose our result to other populations. Of course, the use of TCD has its limitations because we're not measuring a flow, but a velocity. However, no important changes in PET CO2 were noted during the experimentation. And finally, although we controlled as much as possible the menstrual cycle for the 9 women we had, they were not all exactly in the same period. It could have influenced our results a bit. So thank you for listening. I also want to thank my team, who has enlarged in the last few months. I also want to thank John, who shared his squat-stand files as well as helped us interpret this data. I also want to thank Kevin, Miriam, Olivier, and Simon, who helped us with this data collection over the last few years. Thank you.
Great talk there, Lawrence. So it looks like there is a question in the chat from Ronald Skodanoff. I'm sorry if I mispronounced your name. Some have contended that autoregulation is impaired in patients with vasovagal syncope. So we're seeing a hysteresis effect as syncope occurs, obviously as blood pressure decreases.
I'm sorry, what's the question?
There's contention that autoregulation is impaired in patients with vasovagal syncope. Do you think that we are seeing a hysteresis effect as syncope occurs when blood pressure decreases?
It's hard to say. I would say that actually we're not able to say if autoregulation is impaired or not with what we're seeing. We're just observing a characteristic of dynamic cerebral autoregulation. I think that maybe the variability we observed in the decreasing pressure is an inter-subject variability, and maybe some subjects are less able to cope with decreasing pressures, and then maybe it could cause the syncope, but yeah.
All right. Anybody else have any questions for Lawrence? In the meantime, just while we're waiting for one, what do you think would happen if we looked at the same measures but underneath changes in CO2? So if you did a dilatory response or a constrictive response, how would hysteresis change under those metrics?
Mm-hmm. I guess hysteresis would be buffered in the hypercapnic state. Maybe, I don't know. It would be interesting, yeah. So I guess the ratio would be lower in the hypercapnic state when blood pressure decreases. So there would be, the hysteresis would maybe disappear with the hypercapnic state. Hypocapnic state, sorry.
Okay.
Yeah.
Well, I think it's worth checking out. I'll have to examine some of the data sets. I don't see any other questions. So if anyone does have any questions for Lawrence, please send them to her in the chat. And we will have our, oh, sorry, there is a question. Did you observe any changes in breathing patterns during the hysteresis data you just analyzed?
No, so as John explained sooner, we are always looking for, always asking the subject to keep resting breathing, a normal breathing pattern, and we ensure that since we are continuously measuring either the respiration rate or PET CO2, we are usually ensuring that the breathing pattern is similar throughout the 5-minute squatting period.
Perfect. All right, so I hope that addresses the question. And then if there's any others, please send them to Lawrence in the chat. In the meantime, I'm just going to introduce our next speaker, who is Audrey Drapo. Hopefully I used my French accent enough on that one. She's also a PhD student working with Patrice Bessard at the University of Laval. And her talk today is on dynamic cerebral autoregulation of endurance-trained men following 6 weeks of high-intensity interval training to exhaustion.
All right, so thank you very much for still being here, and thank you for the organizer and for John for asking me to present during his seminar. So today I'll talk about my master's degree results, which are concerning dynamic cerebral autoregulation of endurance-trained men following 6 weeks of high-intensity interval training to exhaustion. So it is highly recognized that regular exercise induces, through the modulation of training variables such as frequency, intensity, and duration, beneficial physiological adaptation, namely in the skeletal muscle and the cardiovascular system. But what about the cerebrovascular system? So in a nicely done review by Lucas and colleagues, it has been shown that exercise-induced effects on the brain can be either direct through an increase in shear stress or an increase in neural activation, or indirect through the improvement of the systemic cardiovascular system, the skeletal muscle, or the metabolic system that can alter brain structure and function in a positive way. So when focusing on trained individuals, we expect beneficial effects on cerebral hemodynamics. So indeed, some investigators have shown that cross-sectionally, lifelong aerobic exercise can increase cerebral blood flow and cerebrovascular reactivity. But when looking specifically to another regulatory mechanism, such as dynamic cerebral autoregulation, the impact seems more equivocal, specifically in endurance-trained individuals. For example, some research group did not observe any association between endurance training and dynamic cerebral autoregulation. However, our research group and others have previously demonstrated that elevated cardiorespiratory fitness was associated with an diminished dynamic cerebral autoregulation. So which led us to wonder what would be the longitudinal effect of training per se on dynamic cerebral autoregulation. So we had the opportunity to investigate some endurance-trained individuals that were participating in a study that was collecting determinants of performance in response to 2 different types of intensity, of high-intensity protocol. So a submaximal that was 80% of maximal aerobic power, and supramaximal that was 115% of maximal aerobic power. So in those athletes, we collected the determinant of performance, but also cardiac imaging and cerebral hemodynamics. So the following presentation will focus on the cerebral hemodynamics. So the objective of our study was to characterize resting cerebral hemodynamics and dynamic cerebral autoregulation before and after the 6 weeks of high-intensity interval training that was performed until exhaustion. So, and since we had designed for performance, comparing two different types of training protocol, we had the secondary aim that was to compare the effects of sub and supramaximal high-intensity interval training on the cerebral hemodynamics. So for that, we recruited 19 endurance-trained individuals that were training between 5 and 12 hours a week. They were all healthy and consented to participate in the study. And the experimental protocol consisted of 3 visits before and 3 visits after the training, the 6 weeks of training. So on the first visit, we did anthropometrics measurements, and we did a maximal oxygen uptake test. And on the second visit, we did the maximal aerobic power test in order to individualize every training protocol, since it was specifically 80% or 115%, depending on which group the individual was randomly assigned. And on the third visit, we took resting hemodynamics, and we characterized the dynamic cerebral autoregulation using the repeated squat stand maneuver, since it has a great reproducibility and it increases coherence, making it valuable for the interpretation of transfer function analysis, as John presented. And during the third visit, when we did the characterization, we did measurements that were done continuously. So we measured blood flow, blood velocity, gas exchange, blood pressure, and heart rate. So for the results, all of the resting, systemic, and hemodynamics basically did not change with the training protocol. However, we saw a significant decrease in the resting heart rate, while all other variables did not change. Now presenting the dynamic cerebral autoregulation at 0.05 hertz, which is the squat stand every 10 seconds. So as you can see, we had a great coherence near the values of 1. However, we did not find any significant change between the pre and post training for the gain, the end gain, and the phase. Now looking into the 0.1 hertz maneuver, which are squat stand that are done every 5 seconds, we still had a great coherence, and we did not find any significant differences between the pre and post stage. However, we were able to observe a decrease in the phase, which is an indication of an alteration in dynamic cerebral autoregulation in those specific individuals. So as a summary, since we and others have been able to demonstrate that endurance-trained individuals cross-sectionally demonstrate an alteration in dynamic cerebral autoregulation, we now are able to show that longitudinally 6 weeks intervention using high-intensity interval training induces an alteration in dynamic cerebral autoregulation, as shown by the decrease in phase, which was independent of the intensity of training protocol. So the future perspective that could be considered would be in a future study to actually test the reproducibility of this design, which was pretty demanding for the participants, since we were asking them to train every session until exhaustion. So it was not just doing high intensity interval training, but it was to do it until exhaustion. And it would be great to have a control group, and this way we would be in a better position to isolate the impact of HIIT training per se. A second perspective could be to evaluate the residual impact of high-intensity interval training. So since it was discussed a little bit in the chat room, it's still hard to convey that the decrease in dynamic cerebral autoregulation is actually an impairment when everything else seems beneficial for the health of the athletes or the endurance-trained individual. So, and we don't know if it's something that is actually happening only in the short term, because we tested our participants 72 hours after the end of their 6 weeks of training. So we don't know if that alteration is maintained in time. And lastly, one of the things would be to consider continuing the characterization of cerebrovascular function in response to high-intensity interval training, as it's been presented in another great seminar. We don't know much about what is going on in the cerebral vasculature in response to high-intensity intervals, so it could be interesting to actually measure what is going on during one effort boot. In our team, we were able to present the results in women, but we don't know what is going on in men. So thank you to all my colleagues and the fundings, and a special thanks to all the people that contributed to this project.
Well, thank you very much for the great talk there, Audrey. Does anyone have any questions for Audrey? They can just post them in the chat. From AJ Rosenberg, thank you for a great talk. Why was only 6 weeks of HIIT training chosen for the study? Do you think the results would be the same with a longer intervention?
That's a great question. It was determined actually for the portion, sorry, maybe it's better if I go back. I had said that the individuals that we tested were part of a larger study where we were actually studying the determinants of performance. So what was specific with those people is that 6 weeks was enough to actually see an improvement in their cardiorespiratory fitness. So what we were interested in was to study whether those people that have an increase in cardiorespiratory fitness, does it impact dynamic cerebral autoregulation? So 6 weeks seems enough to have an impact on cardiorespiratory fitness, and now we see that it alters dynamic cerebral autoregulation. But maybe 12 weeks could also be interesting. There was a study with Smirl's team that actually did 12 weeks of training, and they have seen some changes in their parameters. So it could be interesting to do it longer, but the specificity of our program was that it was high intensity done to exhaustion. So it's quite demanding for athletes that are actually performing and competing in their endurance trained sports. So I don't know if it would be of an interest for participants.
There's another question here from Caroline, and she is saying, these are otherwise healthy subjects, correct? Have you thought about examining these effects in patient populations with major cerebrovascular impairments prior to the exercise training?
I didn't catch the rest of the question. So in our participants, they were all healthy. And her question is if we would have done it with
patients that have clinical impairments related to the cerebrovasculature. How do you think that would change outcomes with respect to the exercise training?
I think that's a great question. I was actually in the seminar that Patrice did on high intensity interval training. He was introducing people to the fact that it's already been used, the HIT protocol, with people that have cerebrovascular impairment, for example, with stroke survivors or people with cognition problems. So, and it seems like there are benefits for them to do high intensity interval training. The main focus of this study is the fact that there are improvements in people that are cardiovascular or metabolic symptoms. So we see benefits for the values of dynamic cerebral autoregulation, but we still find it counterintuitive to observe an attenuation in dynamic cerebral autoregulation in fit individuals that are highly trained. So I think it's different because of the health status of both individuals.
Yeah, I think that's a fair point. Are there any other questions? All right, well, if you do have any questions, feel free to take down Audrey's email on the slide currently and send her an email. But thank you again for all the speakers today with Joel, Lawrence, and Audrey. And thank you, Pat and Caroline, for arranging the session.
Thanks so much, John. Again, that was a great session here. Let me just get my slide up for the next session. I really appreciate your presentation, John, and all the trainees. Another excellent batch of presentations there. So just to highlight our next session, which will be on November 24th at 11 a.m. US Central Time. The keynote speaker will be my good friend and colleague, Dr. Trevor Day, who's a professor at Mount Royal University in Calgary. And he'll be focusing on cerebral blood flow regulation during incremental ascent to high altitude, the effect of superimposed hypoxia and hypocapnia. And that will be followed up with 4 great presentations from trainees from Canada and from Ireland to kind of complement Trevor's presentation. So thanks so much, everybody. Really appreciate your attendance today. Thanks to John and thanks to all the trainees for some great talks. And we'll see you in a couple of weeks.